Welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and MRF Institute. My name is David Flench. I am the president and CEO of the Medical Fitness Association. I'm co-hosting this episode with Jeff Young, adjunct lecturer at York College and co-founder of the Medicine, Rehab, and Fitness Institute. Hey, Jeff.
Hey everyone, we are excited to have with us today on our show Dr. Jonathan Bonnet. John is a physician who's board certified in family, sports, obesity, and lifestyle medicine, and an associate professor at Stanford University School of Medicine. Additionally, John is the program director of the medical weight loss, at the Clinical Resource Hub Weight Management Center at the Palo Alto VA. Hey John, how you doing today?
I'm doing great. How are you
All
doing,
right,
Jeff?
I'm doing well. So let's start with you sharing more about your background with our audience.
Sure, yeah. So my background really started in exercise and fitness. So I'm an 8-year Buckeye, but I majored in exercise science and then actually got an ACSM personal training certification. Actually worked at Anytime Fitness before ultimately going into medicine, and then felt like I was going to do sports medicine, and so did family medicine on the way to doing sports medicine, and then sort of got interested in obesity medicine, and then also sort of, I guess, added lifestyle medicine along the way. So a little bit long journey, a little circuitous, but I think by and large, my passion really has been trying to promote health and wellness in people and figuring out the most helpful tools and ways to do that.
Well, you've done quite a bit already in your career. Last year, you were the MFA annual conference keynote speaker, and you presented a session on incorporating lifestyle medicine into medical fitness centers, understanding its role in obesity treatment. So first, maybe tell our audience more about what lifestyle medicine is, and then how does that fit into a medical fitness center?
Great question. Yeah, and hopefully there's getting more notoriety behind what lifestyle medicine is. But I mean, for probably the 10 years I've been in that space, my parents probably still didn't know what it was. So I think people are not alone if you haven't heard it yet. But it is a rapidly growing field. There's about 11,000 members now in the American College of Lifestyle Medicine. So it is a medical specialty, or I guess subspecialty, where you can get board certified. But the real premise behind it is a real purposeful attention to the lifestyle behavior changes that we know have such a dramatic impact on morbidity and mortality. So it's not to say that pharmaceuticals or surgical procedures aren't, have their own place and are incredibly valuable. It's just trying to focus on lifestyle first. And so I think the easy way to think about, give you like a framework for what we tend to focus on in terms of the behaviors that seem to matter most. I'll steal David Katz's phrasing here just because it's easy for others to remember potentially too. But it's what we do with our feet, our fork, and our fingers. And then it's sleep, stress, and love. So if you think about this, so your feet is your physical activity, your fork is your diet or what you put in your mouth. Fingers would be sort of avoiding or minimizing risky substance use, things like tobacco, alcohol, things in that nature. Getting good, adequate restorative sleep, having ways to cope, manage, and deal with your stress, and having loving, meaningful social relationships in connection with the people around you, yourself, and a higher power if you so desire. So those are probably the major pillars that most people would ascribe to in lifestyle medicine. And again, tremendous research and evidence supporting both their efficacy of improving morbidity and mortality, but I think most importantly, improving the quality of life.
Great, great recap of what that entails. So I really think that in medical fitness centers we see that quite a bit. How do you feel like the two fit together?
I mean, I've loved the concept of medical fitness probably for as long as I knew what it was. And so to me, I think there's a critical tie that really we haven't quite bridged the gap between fitness and medicine. I think we're getting there, and certainly the MFA and other organizations are doing a really wonderful job of trying to promote that and support that relationship. Because we know that exercise is arguably maybe one of the most important things one can do to improve health, wellness, prevent, treat chronic disease. So, I mean, to me, one, just fitness in general is part of lifestyle medicine. So MFA and any medical fitness facility truly is a lifestyle medicine first facility. I mean, that is your primary tool that you are using. But I think, most people even who work in the fitness space or, at clubs or gyms or anything, we realize too that there are other things that you're helping people with. I mean, health coaching, certainly behavior change, people to get the most out of their workouts or meet their goals, whether they be weight related or performance related. I mean, you cannot neglect, the recovery piece or the performance piece or fueling piece. So I think inevitably you're still going to be dealing people who are going to have some of these other things that can be worked on and prioritized. So depending on what resources the facilities have, I mean, obviously you could offer all these services, which would be my dream, where you have, dietitians available for people to help them, work on their diet and correct things. Again, ways to manage stress, feedback on their sleep, and then also obviously a pretty robust fitness program too. But the nice thing about lifestyle medicine is all these things spill into one another, right? You rarely have an isolated, perfect exercise program and none of the other cylinders firing at all, right? I mean, the more you exercise, people tend to start eating better, improves their sleep quality, they're less stressed out. So all of a sudden, even if you just start with one of them, which I think fitness is, personally my favorite, but if you start with one, I mean, again, you're going to start to see the spillover effects in all of those other domains too. So I think it's a real opportunity to maybe people come in the door for the fitness program or for rehab or whatever it ends up being, but then to also bring them along for the ride for all those other pieces too as they follow.
Hey, from a policy changing standpoint, I just noticed today when I was perusing LinkedIn that the current, I think maybe the president-elect of the AMA and the chair of the board, right? And it looks like they're going to be lifestyle medicine certified by the end of this year, if I read this correctly, right? So that's potentially big news to get again from the higher level to get some change going on. So I'm assuming you're aware that's going on.
Yeah, this was big news. Probably
Yeah.
dropped, I don't know, a week or so ago at the AMA
Oh,
conference.
okay.
And yeah, it was shared by the ACLM leadership. And I mean, truly remarkable. And again, I mean, it's a nice snapshot of, hey, lifestyle medicine people are, going to be in the leading roles in, the largest medical organization, in the United States.
Right.
But again, like the foundation for this started, decades ago or 10 years ago, right? I mean, the Board of Lifestyle Medicine came to fruition in 2017. So it's been around for, 7 years. And, it takes a lot of time to build up the notoriety, the credibility, and just the awareness of how important this is, and create all the training and education, and also convince people that they should do it. So it's really exciting to see that a lot of people in medicine have like taken this very seriously, and I think a lot of that is because we've really housed this in evidence based. This is not just go out in the yard and sing and dance and hope that something happens. Like this is real science with data and real research being done that really demonstrates its efficacy. So yeah, I think it's exciting times for lifestyle medicine, and it's wonderful to see leaders in positions that are going to have the opportunity to really put this at the forefront.
Yeah, and just so piggybacking off what you just said, just so the listeners know, I've known John. We met in 2016 at a lifestyle American College of Lifestyle Medicine conference. So I've known him for 8 years. We're getting closer to a decade. We've co-authored a book together and all that stuff. But what you just said was reminding me that when I got involved with the ACLM back a year before that in 2015, if I remember correctly, the membership was only about 700 strong. So the fact that right in that amount of time or that period of time, it's gone from 700 to approximately 11,000. And I've been fortunate, a lot of it just knowing you and our
Mhm.
collaboration over the course of that time. Uh, I've been able to see the evolution of the ACLM, and it's so you're right, it is exciting times, and it has been cool for me to see the evolution and the organization grow and doing the amazing things they're doing, like what they are with the AMA, and hopefully it'll just continue.
Yeah, I mean, I remember when I first got involved and went to my first conference in 2013 in Washington, D.C., there was only a couple hundred people um, at the conference or even probably aware of the organization. So, yeah, it really has been exponential growth. And just to see that has been, again, right time, right place. But it's been a fun ride thus far to see, the growth and expansion. And again, I think just lots of wonderful opportunities for anybody who's interested in that space.
Absolutely, and again, because of the ACLM, I met you, and because I met you, plenty of the opportunities that came out of that. But I'm going to switch gears here for a second and ask you a slightly off-topic question. As a physician who practices obesity medicine, you're board certified in obesity medicine along with all the other things you do. you're aware of and in the midst of the tug of war that's going on in that field, where some believe that obesity medications are for life. Once you're on them, that's it. You need to stay on them for life. And some think that they're a tool in the weight loss toolbox, but that lifestyle medicine should be the first line intervention, or alternatively, that the medications can be the first line intervention, but that many patients can be weaned off of them, at least at some point, and placed on a lifestyle medicine program. And I'm not going to get into it, but I know you're aware there was a recent article in the Journal of American Medical Association talking about this and talking about starting people off the medication and then that 12 to 18 month period, weaning them off. In the article itself, it was food as medicine, but we're talking about lifestyle medicine here. And I'm just curious where you stand on this issue.
Yeah, I mean, so my day job now is doing obesity medicine full time, so I get to address this every day with patients and in practice. So it is a privilege, and it definitely has been a fun time to be in the obesity medicine space too, with all the new tools and medications we have available. And I think I'll just premise with, so I'm very much an and person, right? It's not medications or lifestyle. If you choose the medications, it should be medications and lifestyle, or lifestyle and medications. So again, I think the two really should not be disconnected. They really should be joined together. And that's actually the only way you're appropriate, or you're supposed to appropriately prescribe them, is in combination as an adjunct to a reduced calorie diet and increased physical activity. So this is like written in the package insert on the FDA labels for the GLP-1 medications, which is what I think you're alluding to.
Yes.
So again, they are an and. It's not a, hey, just take the meds and don't worry about it. But yeah, I think there is certainly a role for both of them. I mean, obviously, I think lifestyle is clearly preferred. So if patients can lose weight and be successful via lifestyle changes alone, I mean, you're gonna have very minimal costs. You're gonna have minimal, if any, side effects, and most of the side effects, by the way, are gonna be good. And certainly a safety standpoint, it's going to be, an obviously a great choice. So I think for all those reasons, I mean, you wouldn't want to use medications if you could do it with lifestyle. So I think certainly in our clinic, and again, I think this is a differentiator because we do use a lot of medications. We use bariatric surgery. Again, it's for appropriate patients. And I think that's the key here. This is not, hey, I want to lose 5 or 10 pounds. Like I want to go get a prescription for this and get on some meds so I can do it. The patients that we're seeing are very significantly impaired and have lots of comorbidities related to the obesity itself. So these people also have type 2 diabetes, or high blood pressure, high cholesterol, or sleep apnea, or fatty liver, or heart disease, or cancer, many other things that obesity tends to run along with. And so I think for those people, it's a very different discussion of a risk benefit analysis. And no one comes to our clinic having not tried to lose weight before. So it's not like, hey, they show up and the first time they've ever decided, hey, I'm going to lose weight, I'm just going to go get some medications. We typically have, we're a referral service. So basically you have to get a consult, and typically you have to have already gone through multiple comprehensive weight loss programs to really get to us. Then you say, hey, this still isn't working. I need more above and beyond, what a lifestyle program would entail. And I think for most people, I think it's helpful to understand how much weight most people expect to lose with different approaches. And because I think the magnitude does matter. And so lifestyle programs are pretty consistently able to do 5 to 10% of body weight loss. And so again, weight loss is usually reported in percentages. So just for the listener, a 5 to 10% body weight loss, let's say, if you weighed 200 pounds, 5% would be 10 pounds, and 10% would be 20 pounds. So usually it's reported as a percentage. So lifestyle programs can pretty consistently get you in that 5 to 10% of body weight, which is fantastic. There's tremendous health benefits involved with that. And I think for most people, that's a really perfect goal to shoot for. But I think what we're talking about, certainly with medications, is surgery. I mean, you have people who have a lot more excess weight that they need to lose to improve their health. And so lifestyle alone may not be enough for them. Even if they are doing the lifestyle things, you can imagine people with, a BMI of over 40, or who weigh 400 and some pounds. I mean, it is really hard to be physically active. I mean, just the sheer mass and pain on the joints, or even be able to move and have the mobility to do things safely becomes a real problem. So again, I think it's about using the right tools in the right patients to help them achieve health and wellness, whatever that looks like for them. I think your question about, well, what are we going to do with these meds? Are they going to be on them forever? I mean, I think there is a significant camp that feels like obesity is just a chronic disease like every other chronic disease. So we have high blood pressure. If you think about the analogy there, if someone comes into the doctor and their blood pressure is elevated and they get started on a blood pressure medicine, when they come back for their next visit, we check their blood pressure and all of a sudden it's normal. The doctor doesn't say, well, great, let's take those blood pressure pills away. You don't need them anymore. They say, fantastic. Here's refills for a year. See me next year and I'll give you another year's worth of refills. So for every chronic disease that we basically treat with medications in the medical system, we don't necessarily tell patients up front that you're going to be on this for the rest of your life. But the truth is, if you don't make substantial lifestyle changes to reverse the process, you will be on them indefinitely. And this is like cholesterol medicines, blood pressure medicines, diabetes medications. In lieu of a significant change in your overall health behaviors or environment, you probably will be on those things indefinitely. And so I think when you're talking about obesity, if you view it just as a chronic disease like these other conditions, the thought process should be very similar in that we are probably not only going to have to help people lose the weight, but then we are going to have to support them maintaining that weight loss. And again, you can do that through a variety of ways. I mean, the medications are an obvious one, particularly if it helps them lose weight in the first place. Then serves as a weight maintenance medication to keep it off in the long run. Now, what you're referring to was the JAMA article, and I think this was a wonderful idea. I will be clear, it is a hypothesis. There's actually no data to show that this has been done or will work or anything like that, but it is a good thought, right? Because these medicines are incredibly expensive, and people don't like being on medications indefinitely. And once they stop seeing weight loss, there is some recidivism where people all of a sudden say, well, I didn't think I needed the medicine anymore because I'm not losing any more weight. But you definitely run the risk of having weight regain happen after that, which is clearly something you don't want. So I think in those cases, I mean, it really is super critical as people are taking these to be working on all of the lifestyle changes that we're trying to cultivate, right? So improving the diet, beginning the exercise program, starting resistance training, improving sleep, stress, dealing with any underlying emotional issues or mental health problems. So if they do get to the point where they say, hey, I'm really happy with my weight, life is good, I want to try to wean off of it, you now have a robust lifestyle intervention that is ongoing that the patient is now entrenched in, right? So you've built all these habits while they've been on the medicine because the medicine hopefully has made it easier for them to make healthier food choices. And so the idea would be you give them an off ramp where they can hopefully at least taper off the medicine some, potentially stop it. But again, you really have to have a robust program in place to pick up the slack where the medicine is no longer maintaining their weight, but now this lifestyle program is doing its job and helping them keep it there.
You first of all, I agree with everything you said. And you and I haven't had the chance to talk about this yet in any detail, but as you know, I'm a doctoral student in kinesiology, and I'm extremely passionate about this topic. And I've had the luxury and fortunate experiences of being able to work in the front lines at like Duke University Medical Center's Diet and Fitness Center, a leading medical weight loss facility, UCLA, Mount Sinai, Beth Israel. And without going into too much detail, and piggybacking off the last thing you just said, what, if I remember correctly, the ACLM's position statement on obesity medicine or on this topic, they kind of allude to at the end, and I think in just the form of like a one sentence, that many lifestyle medicine programs are underdosed,
Mm.
and that's going to be what my dissertation revolves around, and that's what I think the problem is. And so you actually kind of hit on that at the very end of what you said, a robust program. And what I'm going to do in my dissertations are going to be three groups: a control group, two interventions. One intervention group is going to purposely be usual care or standard care, which I believe, and we won't get into it today, but I believe that usual care and standard care is actually underdosed. And I'm operationally defining underdosed as not really providing enough of a mental and physical or physiological stimuli
Mm.
to um, to promote long-term changes in adherence. So I'm including the behavioral aspect as well, and I think that we could do a lot better. So my other intervention group is going to be a truly comprehensive, intensive. I also feel like from a practice and a research standpoint, they'll use the word intensive, but then when I look and see what they're doing in the research, I wouldn't call a lot of the stuff that they're doing intensive at all. It's walking programs, it's stuff like that. And yet they're calling that intensive. And that's the part that I disagree with. So I agree with everything you said. And I am hoping that my research is going to then start providing uh, uh, data that, yes, we actually can for example, there's always going to be people who fall into the different categories, as you noted, the people who
Mm,
are likely going to need to be on it for life, and that's for whatever reasons, and people who will do really well with the lifestyle medicine program, and maybe they don't need to be put on at all, and everything in between. But I want to try to show with my research that we're underdosing, and I want to try to show what that means, and that when you actually are doing things properly from a diet, physical activity, and behavioral standpoint, and you're providing the support and also creating informed consumers, so it isn't just, hey, go do 150 minutes a week. Just go strengthen your 2 days a week, and make sure that the weights you're lifting are challenging. I just
mm,
don't feel like that's enough information. And that if we create informed consumers, exercise science, nutrition science, even behavioral science, in my opinion, are not rocket science. And I feel like everyone can at least learn the basic foundational
mm,
concepts of each. We don't have to turn them all into RDs and exercise physiologists, etc. But everyone can learn the basic concepts of each and should and become informed consumers. And then that information will then empower them. It's
mm,
a form of both internal and external motivation. And when you merge all this stuff together and create a really big picture, you have that to me is when you use the word robust, that's what comes into my
mm.
mind, and that's what I really want to try to do, and hopefully, in a perfect world, we wouldn't have medications. We don't live in a perfect world, but I would love to be able to have as many people on on an informed lifestyle medicine program as possible, and minimize medications as possible. So there's my response, but I do agree with everything that you said.
Well, Jeff, I have to say I'm excited to read that research study, and I can't wait for it to come out. But yeah, I think just one comment I do want to make, and this has been a challenge in lifestyle medicine, even as a field, is the intensity of the dosing. Which again, many
Yes,
people, when you see research and you say, well, physical activity doesn't do anything or diet doesn't help, and you look at what the actual intervention was, I mean, it really was not that much. And so, if you don't do a whole lot, you can't expect massive changes from it. And I think just a quick example from like some of the weight loss studies, which we're not going to get into today, but for the GLP-1s that were, their landmark trials in like the New England Journal of Medicine, if you look at what the intervention was, so there's a control group, which is considered standard of care, and then there's the intervention group. The control group has to have the lifestyle component in. And the control group lifestyle component was we encourage you to get your 150 minutes a week of physical activity and reduce your diet by 500 calories. And that basically was the intervention, which was advice to give that hopefully people would follow. But that's also the same lifestyle intervention that the people in the drug got. So the drug clearly does work. I mean, you can look at I mean, you don't need statistics to see a massive difference between, 16% and 2% or
yep,
21% and 2%. I mean, you don't need math for that. But you can also tell how robust the lifestyle program is when you only see that the placebo group, which got the control lifestyle intervention, is only 1 or 2%. When I just told you a well-designed program should easily get 5 to 10% of body weight loss. So you can already tell just by a bird's eye view that the lifestyle program clearly was not very efficacious if people basically almost lost no weight on it. So I totally agree with you. And I think that's an important consideration when you're thinking about it. And also, this is probably a little bit tangential, but I know at some point people always ask, well, what about weight regain when people stop these medications? Again, we didn't really give them a lifestyle program to begin with. So if you just take them off the drug, we probably shouldn't be surprised, since we didn't change a whole lot necessarily,
exactly.
that a lot of that weight can come back on. So you can imagine if you actually had a robust program throughout and then actually continuing once the drug was removed, you certainly would probably get different results. I mean, again, we don't have data to say that, but you could presume it's true based on all the other things that we've seen previously.
Love it.
yeah. I'll jump in with, Jeff, you use the phrase informed consumer. And I
Mm,
think that kind of leads into something I want to talk about. There is so much information, some of it's misinformation that's going on right now. And, we're talking about the properly designed exercise programs and dietary programs. There, one of the things I think I hear quite often is how the lean mass, you're reducing not only fat mass but lean mass, and so that's why a strength training program is so important. But we don't maybe know quite fully how much of this lean mass in these studies is muscle mass versus other tissue and so forth, and so how strength training really plays into the whole equation. And not only that, I think I've heard I think in your presentation last year, John, talking about the messaging, and so right along with this is what are we focusing on? Is it about feeling better? Which, yes, that's definitely going to happen with some of these lifestyle improvements. Um, or are we do we know enough to say some of these things about muscle, all that? So I just kind of want to hear your take on that.
Yeah, I mean, I think it's super important to recognize like what is our goal here? Like what are we trying to accomplish and will we know if we get there? I think, for research studies and certainly for drug approval, they have very clear, concrete endpoints, right? And so for weight loss studies, for better or worse, the endpoint has been amount of body weight lost in pounds or kilograms, right? So it is just a number. How much weight did this person lose? It does not differentiate what kind of mass that is, whether it's muscle, water, bone, or fat, which is a real problem. And there's been lots of pushes to get people to do this. And again, we're basically limited to subgroup studies that look at DEXA scans of people so you can actually see the body composition. And that's where some of the concerns have come up. And I can tell you clinically that it is a problem. But I think more importantly, there are lots of ways we can fix this. I mean, I know there are many drugs in development now to try and give you another agent to boost your muscle mass while you're taking a weight loss drug. And I'm just thinking, oh my gosh, are we going to like pharmaceuticalize every intervention that we can think of? I mean, it's very clear that the most robust way to maintain lean muscle mass or promote it is resistance training plus sufficient protein intake. Doing those two things will maintain your lean muscle mass. And even when you're losing weight, there have been pretty impressive studies suggesting the majority of weight you can lose can be predominantly fat, with a robust, again, probably 2 to 3 times a week at least of a full body resistance training program and getting adequate protein, probably at least 1.2 to 1.3 grams per kilogram, probably at a minimum. So if we get people doing at least that, I think I'm much less worried about the concern for the lean muscle mass loss. I think what we struggle with is we're still not getting people even to that. So yeah, we can try to develop more drugs, but I think to me, the obvious thing is get the fundamentals right and then worry about supplements, medications, and everything else after the fact. But I do think the messaging is important here about this is not about just changing your scale weight. I mean, most people will tend to focus on that because it's easy, it's obvious. You get feedback, you just step on the scale and you get a number, right? But then they ascribe success or failure to whether that number is moving in the direction that they want. And the concern with that is, again, I mean, losing muscle mass to me is not success. I mean, that is not a good thing. Um, if you're trying to add, build muscle, gaining a bunch of fat mass to me is also not a good thing. So the scale can be deceiving, but I think, again, when I do goal setting with patients, I try and not fixate on a goal weight, but I really focus in on behaviors, right? Because we know all the behaviors are the things that are going to predict good health outcomes. I think at the end of the day, though, it's also really important to realize that, I mean, I can tell you personally, I have never worked out thinking, I'm glad I'm reducing my risk of heart attack 50 years from now. This is going to be a really important workout today for me to do. I don't think that way. And maybe there are a few people who do, but most by and large, I exercise because it makes me feel good, gets to challenge myself, um, improves my cognition, decreases stress. And so it's very rewarding in and of itself. Right. And so I think to really get people on that motivation bandwagon, you have to convince them this is not for some 50-year from now future self. You have to convince them that this is for you right now, today and tomorrow. And I think when you can connect the dots for them that, hey, you are going to feel better, you are going to function better, your life is going to be better, all of a sudden that becomes a prize very worth trying to achieve. And so then you can bring them along for the ride and help to get them facilitate all those healthy behaviors we want them to work towards. But again, I think if you lead with just well, you need to lose weight to improve your blood pressure or your cholesterol or, reduce your risk of cancer. I mean, that's all true and that's wonderful. But again, I think for most people, that is not going to connect some intrinsic motivation that's going to get you in the gym, at 6 a.m., 5 days a week. Like that's not going to be the thing that's going to keep them going. So I think, just realizing we're all people and we all have, relatively short-term drives and we want to feel good and function well. And that doing hard things needs to be rewarding in some way, or we're not going to keep showing up and doing it. So I think if the more you can sort of leverage human nature, I think the more successful you will be in not only convincing people to do it, but keeping them around to really accrue all the benefits.
That's fantastic. I know
Yep.
we could spend, a couple of hours probably on this topic, but thanks for hitting on some of those important aspects. I'll kind of shift gears a little bit here. I want to talk about how, historically, healthcare has been a volume based and focused
Mm.
on treating the sick. And I think, and it's probably very uh, similar to the timing of lifestyle medicine getting more prevalent and popular. But there's been a lot of discussions, I would say, over the last 10 to 20 years about moving more to a value based approach
Mhm.
in healthcare, that goes right alongside of a focus on prevention and wellness. And those discussions do have momentum now in a lot of ways. So I want to know from your perspective how you think the focus in healthcare can turn even more toward that value-based approach, where it's not just about every procedure that gets done, but it's about a lot of the outcomes and looking outside of some of the traditional methods. So how can we move that even further?
Really good question. And yeah, I mean, healthcare is overly complicated, unfortunately, and thankfully we are moving to, I think, what are better systems. And again, what you really want to do is align everyone together, right? So you want the patient aligned with the insurance company, aligned with the hospital or the doctor who's providing the care, right? You want everybody to do what is in their own best interest to have an optimal system, right? So when you have disalignments, all of a sudden then you run into problems. And so the historic model has been what's called the fee for service model. Basically, you go into the doctor gets paid for the more things he does to you. He writes a prescription, higher billing. If he does a procedure on you, more billing. He comes back and has you come back to the office 5 or 6 times. Again, more billing for every time you to have a touch point with them. So in some ways, that's good, right? I mean, doctors are getting paid for the work they're actually doing. The problem, though, is you're actually incentivizing people to do more things, right? The more times I see this patient, the more I'm actually getting reimbursed. And I'm not here saying that I think doctors are actually quite genuine and quite honest about the things. But again, you still put a economic incentive to do more stuff for the patient or to the patient. Because again, you're getting reimbursed for all those things. So the shift into the more of the value-based care, the idea behind it was what we care about here is the outcome of health on the patient, right? We want that to improve. And so we don't really care how you get there, but if that takes 100 visits to get there, or you can do it in one, we don't care as long as the endpoint is the same. So in theory, that's great because now you have the system operating in a way that is going to hopefully at least align the patient and the doctor on, well, I'm going to do what needs to be done to improve health. The worry with a system like that, though, is if that outcome that is being measured is not appropriately assigned, you now have very bizarre things that can happen. So, for example, if the health system only cares about a hemoglobin A1C, that's the only thing they care about, doctors will do everything to lower the A1C, and they will tend to do it in whatever is the least expensive way possible. So, you could be getting, in theory, worse options. You may get less expensive medications that still lower A1C, but may have other risks associated with it, or may increase cholesterol or something else. Or you just may have them not using a surgery or procedure because they know the procedure is expensive. They'll try the lifestyle thing instead, or vice versa. So what you want to make sure is that whatever the outcome is in the value-based system is that it comprehensively is covering all aspects of health, not singularly focusing on one thing. Because if you just focus on the one thing, it is very easy to create a very warped system where the things that people are doing don't really make sense in terms of providing better care for patients. They actually are just designed to save money, right? Because anytime you save money, you win, right? If it costs you less and you can get a similar outcome. So you're not necessarily totally aligned still. It's definitely better than fee for service. But again, you just need to be really careful about those incentives because you can create this very bizarre system where incentives actually end up being misaligned because, again, the focus is now on now I want to do as little as possible and hopefully still achieve, what I'm being measured on.
Yeah, I love, your thorough answers and the insight that you give on this stuff and appreciate it. I'm going to switch gears a little bit here. This is the Medical Fitness Podcast powered by the Medical Fitness Association and the MRF Institute. And you've known me long enough to know that I'm extremely passionate about building the bridge between medicine, rehab, and fitness. I mean, and admittedly to a fault. Like I honestly, think about this stuff every day.
Mm.
So in any case, this includes clinicians ensuring that they have fitness professionals in their overall wet network. And in my nearly 30 years of experience, that's just not happening often enough, and the associated referrals of patients when appropriate. I totally understand that we don't live in a perfect world, and we're not going to get 100% referrals or 90 or 80 or 70 or 60 or 50 or even 40, but I just feel like it needs to be more than what it is. So as often as possible. So my question to you is, what's your message to your peers on this building the bridge topic? How do you think that we can optimize this pathway?
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.
I wish I had a better answer, because certainly I would be doing it if we could optimize it better. I mean, I think again, it's very clear how important and impactful physical activity are, and I think it's great that we have fit prescriptions that we can give to people, from a clinician's office. And there's been a lot of work with exercise as medicine movement, wonderful ways that you can sort of help incorporate that. But I think we are still a little bit short, though. I mean, I think even giving the patient the prescription, is miles ahead of where we used to be. But at the end of the day, I mean, it really depends what the patient does with that. I mean, they just throw it in the trash on the way out. I mean, we haven't really gotten where we want to get. And again, I think that's improving, the overall activity levels. But I think more importantly, again, there's a difference between just, hey, them being more active and moving around versus being on a purposeful exercise program designed to improve some aspect of fitness. So I think this is where I think there's such a wonderful opportunity to partner with the medical fitness community, because I mean, it is not easy to design a progressive, overloaded resistance training program. I mean, if you're thinking about how people move, the exercise selection when you're dealing with injuries or chronic diseases, I mean, all of a sudden becomes very complicated. You can't just say, well, do some squats, some push-ups, and pull-ups. I mean, that's great, but many people cannot do those movements correctly or have access or even the ability to do them. So they're great functional movements. I totally agree. But if I lined up 100 personal trainers here and said, I want you to write a total body resistance program, they'd all be different. So there is just tons of variability here. So you can't just give a cookie cutter sheet that says, hey, here's a full body workout, just do this indefinitely and you'll be set. Most people really are going to need some guidance. And more importantly, they probably need some accountability, right? Because you're just not going to have touch points with a physician's office typically frequent enough to actually get you on board with it, help you adjust the program as needed, measure all those variables, go through the movements. I mean, you're talking about a lot of attention to detail that has to go into designing stuff like this, particularly for the resistance training piece. You could argue that cardio, people mostly know how to walk, but I'd say, people shouldn't be walking forever, probably. They should be increasing their distance or their intensity or doing some intervals or doing some cross training. So again, there's just lots of variables that, I think people can spend lots of time thinking about. And so to me, again, it's good use of resources, right? I mean, I can't know everything as a physician. That's why I send people to other specialists or to other allied health professionals to help them or to help the patient and allow those other professionals to really do their job. They will do a better job than most physicians will do because they have the time, expertise, training, and familiarity with doing it all day, every day. So to me, again, it's just good use of resources in the community. I think the challenge historically has just been there's just not an economic or financial way to get it approved. And so that patients basically end up paying out of pocket for this. So I can send a patient to a dietitian, and insurance typically will cover a number of visits for them every year, or there's just a small copay. If I send a patient to a personal trainer or an exercise physiologist, generally, unless there's a health condition or something that they're being sent for a stress test, that is all out of pocket money for a patient. So all of a sudden now you have dropped this bill on the patient and made them the one responsible for paying. And so again, it's a misaligned, financial incentive there where all of a sudden the patient really has to care about it and have the resources to do it. So I think if we could refer to a fitness professional, just like I could refer to a dietitian, we would see dramatic increases in the utilization of it and probably also just general activity levels of people and probably their health too. But again, that's just not the way the economics are, but we have the Physical Activity Alliance and, many others trying to work to change this. And I think we will get there. But I think, it's still going to take some time to actually change. Anytime large amounts of money are being shifted or changed, there's a lot of people who want to get involved and, fight for their little piece. But I think it's very clear that the value is certainly there. And so I'm hopeful that we're moving into that direction, because I think medical fitness facilities are a beautiful place to do all this. I mean, you have a medical setting, it's very safe, it's controlled, you have experts there helping people to progress, and also, again, have the community and engagement piece. And again, you're connected with a medical facility. So if there is a problem, you're right there to deal with anything that comes up. So to me, with the aging population, I mean, it's going to be a ripe opportunity for people to be able to engage with those kinds of services.
I can't wait to hear David's response to this, but I want to chime in real quick and just make sure that the listeners are aware, related to a couple things that you said, that yes, there is a movement going on. So listeners, if you are not aware, there is a major movement going on in the background. It's being driven primarily by the Physical Activity Alliance and the American College of Sports Medicine. And uh, for those who are listening to this, you could go to the American College of Sports Medicine's Health and Fitness Journal, the August 2024 issue. There is a special themed issue that is really talks a lot about this. The entire issue is titled "Advocacy and Professionalism Within the Exercise Profession," and I actually co-authored an article within this, one of the feature articles, with the immediate past president of the Physical Activity Alliance, Dr. Amy Bantham, and Dr. Matthew Campert from the Cleveland Clinic. But I just want to make sure that the listeners are aware of this and that we actually aren't too far away. Hopefully, um, maybe, I don't know, 2, 3, 4 years, where there will be a subset of the exercise specialist population, namely clinical exercise physiologists and others who meet the standards, where physicians like yourself, John, will be able to bill for the services of what's being called non-licensed qualified healthcare providers. So we're calling it the QHP movement going on in the fitness world, and it's absolutely going to happen. So so much of it because of the what the PAA, the Physical Activity Alliance, is doing. So we're getting close, and hopefully it's going to happen, like I said, within the next couple of years. But
Yeah.
David, I would love to hear your input on this as well.
No, I agree. The Physical Activity Alliance is doing great work. I mean, it's only been around for a few years. We held. I went to the first symposium last fall. I know they're planning another one this fall, and so it's bringing together a lot of different organizations that are working towards that goal. Several goals that are in this space, and so that's part of the great thing. It's bringing together a lot of people that are working on things, and a lot of progress is being made. I mean, getting it to where the electronic medical records are going to require questions about physical activity to be entered, and so that helps the referral process. So I think, yeah, I mean, MFA collaborates with the Physical Activity Alliance quite a bit, and I think all of that is very important. I'd actually make, my before MFA, my career was in running medical fitness centers. And so I'd actually make the argument that a lot of medical fitness centers are offering these programs at near zero cost to patients. The common program is like a $60 for 60-day program when you get referred from a physician. We had that at our facilities, and they were really popular. And so cost became a little bit less of a concern, and it was a really popular, and many facilities are doing that. The problem is there aren't enough medical fitness centers right now. So it's is there enough trust from physician to general fitness center with you know personal trainers who may or may not have the type of qualifications that we need, and that plays to what you were just saying, Jeff. So I think it is really important to have the right type of credentials, the accredited certifications, and continuing education in this space, that so that you know what you're talking about, and so that there isn't a gap between what a physician is talking about and an exercise professional is able to then administer. um, so I think it all goes together. I think there needs to be more medical fitness centers with the qualified personnel who can put forward. And what actually happens is a medical fitness facility likes to look at those referrals as a feeder system
Mm.
into lifelong lifestyle modification. So yeah, if your doctor wants to refer you, we'll have an inexpensive program. Hopefully over a couple of months you start to form some habits, and then you can continue on. And so I think there's a lot of different ways to attack this. And yes, I do think it's a problem that there's not as much reimbursement in the space, but at the same time, the base price of services at a fitness center, a medical fitness center, are probably a lot lower than the base price of many medical services. Right, so there's some differences there too. But John, do you want to chime in on that?
No, I love that. Yeah. I mean, I wish there was a medical fitness facility as often as there were gyms. Yeah. And I think some of those incentives are great. I mean, I love the idea that it's almost like, giving people a chance to taste it and then saying, hey, this is actually worth your time and money. So I think promo offers like that are fantastic to get people in the door, because I think you can actually capture them and get them to come consistently for a couple months. I mean, the patient will realize the value that they are getting eventually. But in the beginning, it's tough for them to appreciate it, and say, well, I got to pay $60 for that, which again, I mean, in medical care, I mean, that's like nothing. But when it's the bill that the patient gets, that's what they feel, right? When they come to the doctor, it may be 100 or 150 or $200 that they're paying for that visit, but their copay is $25, right? It's $25 to come see the doctor, and that's it. So, for them, they think, well, it's $25 to see the doctor. And then they may not necessarily appreciate how much they're getting, certainly at a medical fitness facility. I mean, those are tremendous prices. I mean, if you think just going to a regular gym, I mean, you're easily going to pay $40 a month just to go to a regular gym and get no instruction and, no oversight and no medical fitness, anything. So yeah, I mean, I think there's a disconnect of just getting more people into that system, but then also just having it around everywhere. I mean, if there's a medical fitness facility on every corner, people would know about it because they said these are all over the place. What I got to do something with them, or what's their deal? So, but again, I think part of it too is just those relationships with the providers. So again, doctors being open to doing it, and then also connecting with the medical fitness facility and understanding what value they can bring, and say, hey, like, I'll take any of your patients that you send me, and we're going to give them this great promo deal for 2 months. So, please send everybody, or whoever you think is appropriate. And so I think then you can sort of get that mutually beneficial thing, because it works better for doctors too, right? I mean, we want our patients to be healthy. We don't want to prescribe tons of drugs to people. Like, we want them to have a robust lifestyle and, enjoy life and have health and vitality. So really, it is an everybody kind of wins situation. I mean, there is a little bit of cost, but again, you could argue that it's not the primary barrier. But again, it's getting the incentives and understanding that the patient recognizes the value of that cost, even if it's small. They still have to appreciate that, hey, this is worth me, paying for, the couple months to come. So yeah, I absolutely wish there were more of them. And I wish there were more patients going to them for sure.
I have two quick comments before we move on to the next question. One is there's officially a lot of pressure on David as the CEO of the Medical Fitness Association to make sure that there is a medical fitness facility on every corner across the United States. So pressure's on you, David, number
I think
one.
that's a
That's my
great
first
mission
response.
and vision for
Yeah,
next
I
year.
do too. That's exactly right. And the other thing, and I'll have to put the link to the article because I can't remember the title of it in the show notes, but I just want to make one really quick comment on the subject of barriers, because Dr. Amy Bantham, who I just mentioned a little bit ago, immediate past president of the Physical Activity Alliance, doctor of public health from an institution that you know a little bit about, John, Harvard University, and she did her dissertation on this, and she has a section within her dissertation on barriers, and I just can't remember exactly what the section is called, but it's barriers and solutions. So I just want to quickly say, I know we got to move on to the next question, but I just want to quickly say that from my perspective, there are, first of all, the big picture is the system's broken, and we all know it, and there needs to be a lot of fixes, and so we've been alluding to that during the course of this whole conversation. We have a very broken system that needs many fixes. From a barrier standpoint, I'm very passionate about, you can pretty much name the barrier, and it's perceived. It's a perceived barrier. In other words, there's solutions to it. And we don't have time to get into that today. Maybe that can be for the next time we have you on. But I just feel like, and she did a good job of addressing that in her dissertation. So again, I'll put the link in the show notes. But I just feel like actually every clinician on this planet and every exercise specialist on this planet should be reading her dissertation, because it is a really great paper on this whole topic, and how to make some fixes. So anyway, in any case, I'll get off my little uh, preaching thing there, and move on to the next question. I appreciate your listening here. But as I wrap up with my last question, John, as I mentioned earlier, I've known you for almost a decade, and I know that you even talked about it earlier, that you exercise. I know you eat healthily. You keep yourself in amazing shape, and you're a huge advocate for progressive total body resistance training as part of an overall healthy lifestyle. I totally know that you walk the talk. Um, what do you think that clinicians should understand about the importance of strength training as a regularly discussed and recommended mode of exercise with patients? And again, I know we talked about that a little bit earlier, so maybe you can just add some thoughts to it. But and uh, and also, do you go about this in your practice when you're talking with patients? Like, how do you go about determining when the time is right to bring up the subject? If not, maybe not to even bring it up at all with certain patients, or just the topic of strength training is so important. How do you go about it, and what advice would you give to your peers?
Yeah, really great question. And yes, it's been a lot of fun over the, I guess, decade or so, Jeff. That's been great. And I have to say, you've written some programs for me, so I'm very thankful and
Uh,
grateful for your expertise as well. But yes, I definitely have definitely it's something I love doing on my side. So yeah, resistance training definitely is part of my life, and I probably do more than I need to do of the resistance training, but it's fun. But yeah, I think, for me clinically, I mean, the reality is there's not a single patient who would not benefit from resistance training. I mean, I guess we could potentially move away from, I guess, children, talking about adults primarily. We all benefit from it. It's all helpful. Again, it's just finding the right movements, the right person, right intensity, dosing, all those things that, ultimately matter. In my practice, I mean, again, I'm doing obesity medicine and weight loss. So again, I'm maintaining muscle mass is critically important. Again, it really does depend on the patient. So, I mean, again, we're talking pretty beginner resistance training. So we send patients resistance bands, so exercises they can do sitting in a chair at home, because they may not have access to the gym, they may not be familiar with movements. So we actually do a whole session with them with a physical therapist that actually shows them how to do full body with just a resistance band. So everything from pull downs to presses to a leg press, hamstring curl, everything just with a band. So we try and incorporate that. I can't tell you everyone actually does it, but we certainly have at least introduced it and, tried to make it a priority for, letting people know that this is really a part of the treatment plan, not just oh, you can do it if you feel like it. But I think to me, though, I mean, the beauty of resistance training, I mean, it just deals with so many things that we see as people age, right? So things like osteoporosis, sarcopenia, falls, mobility issues, even dementia and other things, the cognitive benefits. But I think, when you think all of those things together, I mean, muscle is like arguably the one of the most important tissues that we have to maintain our stability, structure, and our independence. So as people age, what they want to do more than anything is be able to continue to live by themselves, not have to go into a nursing home or facility. How do you do that? You have to maintain your strength. Again, hopefully you've built solid bone mass when you were younger. But again, how do you do that? Resistance training. And again, even when you're thinking about the cardiometabolic effects, I mean, muscle is a sink for blood sugar or glucose, right? And so if you want to avoid, pre-diabetes, diabetes, and insulin resistance, I mean, a robust exercise like resistance training program is probably one of the best ways to mitigate that. And certainly when you're talking about just weight maintenance, I mean, again, wonderful approach to do it, because if you actually do gain some weight, while you're doing a resistance training program, you could be building muscle, which again is going to serve all of those um, different areas of health very well. So again, I mean, the list goes on and on and on, but I mean, there's almost no downside to resistance training unless you do it so much that you get hurt. But again, I think that comes back to what we've talked about this whole conversation is you need to have well-designed programs and instructions for people so that they can do it safely. Because bad form will get people hurt no matter what you're doing. Good form will keep people safe and healthy, and allow them to progress and gain muscle, build bone, improve their health. So again, it's not that exercise is bad or dangerous, but bad exercise form certainly can cause injuries and problems. So I think that's where there is that disconnect of people say, well, I've got back pain, I can't exercise. It's like, well, you can't do certain exercises that'll worsen your back pain with bad form, but there are a ton of exercises that we can do that will dramatically improve your condition and will improve your pain. So I think separating that, hey, the wrong exercises can be problematic for certain people, but the right ones can be life-saving and life-changing. So I think that's really, I think the message that most people need to get is that resistance training is good for pretty much everyone. Even if you want to lose weight, even if you're a woman, you're not going to gain 100 pounds of muscle, I promise. There's just not the right environment to do that. So I think clearing up some of those misconceptions really helps people recognize that there is so much value here. And I think as you're thinking about healthy aging, I mean, I could argue that it's maybe one of the most important things people are going to do if you want to maintain your independence and quality of life.
Love it.
Well, John, it's great having a physician that is able to walk the talk, like Jeff said, and be part of this movement of lifestyle medicine. I love everything that you're doing. It fits perfectly within, I think, what we do at Medical Fitness Association. I think it's great to have folks like you who can keep forward that message. So I really want to thank you for com- coming on the show and sharing all your knowledge and expertise.
I mean, I want to thank you both too. I mean, David, you've done a phenomenal job being at the head of the MFA. I mean, it's honestly an organization I knew about probably 10 or 15 years ago in undergrad. And I thought, oh my God, I'm like, this is amazing. Like they do fitness and medicine together. I'm like, what a cool concept. Obviously, we just need more of it, quite frankly. But I mean, what a wonderful service to offer people. And so I have truly appreciated your leadership and opportunities to, collaborate with you all and speak at your conferences. It really is a wonderful group of passionate people working to change the world. So, definitely thank you to you and obviously to you, Jeff. I mean, it's been a lot of fun hanging out over the years, talking about things, working on projects, writing book chapters, and trying to change the world in our own little way.
Exactly right. I really appreciate it, John. Thanks so much.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Attention, all medical fitness professionals. Get ready for the event of the year. Register today for the Medical Fitness Association Annual Conference, November 19th through the 21st in New Orleans. Network with industry experts and like-minded professionals from around the U.S. and Canada. Gain insights from leading voices in medical fitness and take your career to the next level. Don't miss out on this incredible opportunity. Mark your calendars for November 19 to 21st and join us in New Orleans for the Medical Fitness Association Annual Conference. Register now at medicalfitness.org. That's medicalfitness.org.